Welcome to Empowering Plans, a show dedicated to identifying waste and undue expense in the health benefits industry, discovering ways to maximize benefits while minimizing costs, and empowering employers, administrators, and consultants to emphasize, once again, the benefit in benefit plan. Today's episode is brought to you by the FIA Group, empowering plans since 1999. Now here are your hosts, the FIA Group's own CEO, Adam Russo, and Senior Vice President and General Counsel, Ron
and Brady.
Hello once again. Thank you for joining us for another episode of the FIA Group's Empowering Plans podcast. I am Ron Peck, Senior Vice President and General Counsel with the FIA Group. Next to me, the one and only, thank goodness, Brady Bizzaro. Say hey, Brady.
Hello, Brady.
I said, say, hey, Brady.
I know, I had to be different.
Oh, man, that's good, though. That's good. It's better to think on your own, blaze your own path. Speaking of blazing a path, in recent days, we have formed a new team. I've been calling it the A-Team. I'll actually tell you, I've been looking around, shopping for some A-Team merchandise for you guys so you can decorate the office. The LCARA, or as we like to call it, LCARA, which is very sophisticated sounding, legal compliance and regulatory affairs. Brady, you're not the only one on the team, are you?
I'm not, no. The team actually consists of three of some of our best employees. Well, I shouldn't include myself in that, I guess.
Of our best.
The hubris I have.
The three best. Go ahead and admit it, right?
One of our other attorneys, Andrew Silverio, who's been at FIA for a long time and is a really great addition to our team. And just so happens that the other person on our team is today's guest on our podcast. It's Philip Qualo.
Hello,
Say
everyone.
hello, Philip.
Hello, everyone. I'm really excited to be part of my very first FIA podcast.
So before we dig in and talk about any specific topics and the whole reason we brought you to the table, Philip, why don't you guys tell me a little bit more generally about what the LCARA team is up to, what you guys are going to be handling for our clients and for the company, sort of what your purpose is?
Sure. So other than serving some fancy souffles, which is what LCARA,
Escargot to go.
Fancy restaurant. But in all seriousness, the acronym actually is, I think, perfect because we at FIA sort of identified that we already were doing sort of high-level compliance tasks, both internally and externally for our clients, of course. And we just wanted to sort of formalize a team that would work on some of these more complicated issues that we get. And everyone listening to our podcast knows that nothing is simple in healthcare, and a lot of the issues that we see, disputes involving providers and plans, TPAs, stop-loss carriers, all the new regulations that are coming out seemingly like every hour, especially now, it's a lot to keep up with. And we wanted to carve out of our consulting team a specialized team to focus on just those issues. So we always have updates for our clients when regulations change, when compliance items change. And LCARA's goal is to be at the forefront of those issues to give our clients sort of a summary of what they'll have to do before they have to do it.
So, Brady, I want to cover two things. And Philip, you tell me if you noticed this, okay?
Okay.
First thing is when Brady said that these new rules and issues are coming out every hour, he literally took his arm, pulled his sleeve up, and looked at his watch, which I thought was very theatrical, except this is audio only, Brady, so people aren't going to recognize or appreciate that unless I tell them. So I want everybody to close their eyes and imagine this very dramatic looking at my watch every hour.
And I will say it was very dramatic.
It was nice. I liked it.
Theatrical.
The other thing that I like so much about what you guys are doing is, and this is an interesting part of sort of the relationship between you two in particular, is that Brady, his primary purpose is to service the clients, okay? So these clients, benefit plans, TPAs, carriers, brokers, whomever, they're coming to us and they're saying, hey, I heard about this, or hey, I saw this. What do I need to do to remain compliant? And so Brady was starting at that external level, doing this research, and then what would happen is he would say, not only did we address this new issue for our client, but I actually think it may impact us, the FIA Group, as an employer. We've got, 150 plus employees. We're a full-time employer. We've got our own people. We need to be compliant too, right?
Yeah.
We've got our own plan, right? We've got our own handbook. We've got an HR department. And that moment when Brady would realize, hey, this is something that impacts us as an employer and our plan, he would hand it off to you, Philip. And at the time, you were much more involved or engaged in sort of that internal matter where you're dealing with HR, you're looking at sort of our internal policies, ensuring compliance internally, and sort of that crossroads where externally assisting clients and internally servicing the company, where that meets. you circle that sort of crossroads, that intersection, and that's where this department sort of formed. And I love that it's really that handoff where things we do for ourselves and learn from our own experiences then benefit our clients, and things we do for our clients, we learn from that and it benefits us.
So
and
you're
so
saying
this is crowdsourcing.
You're saying we're a Venn diagram, Ron, basically?
Oh man, we're venting it up, man. I love it. So Philip, so far, obviously it's only been maybe a month or two that you've really more officially been engaged in this interaction. But I think really more or less since you've gotten here, there's been that back and forth between this is what we're doing for our clients versus this is what we need to do for us. Have you noticed that there's been any kind of situation in particular where either you saw that we had to do something as an employer and that blew up into something we were then doing for all of our clients, or reverse, something was identified as a need of our clients and you ended up identifying how it impacts us? So sort of either way.
There have been actually several situations that have arisen that have definitely not only helped us or educated ourselves about keeping ourselves compliant, but definitely allowed us to provide better resources to our clients. One of those primary issues have been paid leave laws, which are, definitely becoming more and more popular among a variety of states, including Massachusetts, where we're based. And, there were a lot of questions that came about because of these paid sick leave laws, because there is a continuation requirement of health coverage in these regulations. So a lot of self-funded plans were wondering, including our own self-funded plans, do we have to comply with this? Because as you know, typically self-funded plans are preempted from state law. However, a lot of these paid sick leave laws are focused on the employers.
Right.
So obviously the entities that are sponsoring these plans. So not only have we been able to advise our clients on, best next steps in preparing or complying with their state paid leave laws, we're also able to take that knowledge to make sure we are prepared as well.
I love that you brought that up in particular because, and I'm sure both of you will agree, so many things come up where the line between employer and plan are blurred, and either our client or, I'll admit it, ourselves, sometimes we forget that those are actually two separate entities. And as an employer in the state, we need to comply with certain rules, regulations, and laws that are focused on the employer, not the plan. So just because a plan enjoys ERISA preemption doesn't mean the employer gets to come along for the ride. And I think that a lot of the work you guys are doing focuses on that sort of the fact that there are these many different entities in play. It's not just one amorphous blob, and you need to ensure that you are compliant with each law in the right category. And I love that you guys are doing that work, and it's just one more of those gaps. When we talk about gap reviews, and it's the whole reason we're doing the employer handbook reviews and leave of absence and things like that, that all came from this work. So I expect a lot to come from you guys. Speaking of great work and things that you've produced, Philip, let's talk about this amazing blog post / article that you published about the hospital transparency and the pricing. First of all, excellent writing.
Thank you very much.
I have to say, we read a lot of articles.
We do.
And, this is without editing. You're just very well spoken, concise, perfect. I like the way you write. So well done. For those out there who haven't read it, we'll make sure it's posted on our social media and elsewhere so that you can see it. Great work. Why don't you tell us a little bit about the subject matter of your recent post here?
First, I must say I'm very flattered.
Oh, stop it.
Very flattered. My head is swelling here for people who can't see.
How would I know good writing?
So what the article focused on was a final rule that was issued in August of 2018 by the Centers for Medicare and Medicaid Services, which hopefully we can refer to as CMS to keep that short.
CMS.
And the rule that I had taken a look at has a lengthy name. It is the 2019 Inpatient and Long-Term Care Hospital Prospective Payment System Final Rule. Wow. So try saying all that with one breath. Yeah.
Oh, man. I like LCARA better as far as acronyms go. I'm just saying.
A little more exotic.
Yeah.
Under this rule, there were several policies, and most of these policies were aimed at making healthcare more patient-centered. And one of those policies, which I discussed in this article, focuses on price transparency, specifically with hospitals. So part of the final rule, which I'll just refer to as the CMS Final Rule, part of this final rule included a requirement that hospitals post their price list online on their internet in a machine-readable format, and I'll define what that is shortly, in a machine readable format and requires the hospital to update that list annually. So machine readable basically just means digitally accessible, otherwise something that you can just import into your own system and can be easily read by your own, processing
See, there I thought
system. So-
machine readable meant you have to be a machine in order to be able to read it. You know,
Well,
it's like in binary codes, like 011001. Yeah, that's some nerd humor out there. Pat's giving me a good chuckle. You appreciate that one, huh? All right, Pat the man.
Well, keep listening because you might actually be right.
I was
Ron.
just going to say, because, we have this rule has been in effect now since January of 2019. And before I give some feedback on what I have seen so far when it comes to compliance with this rule, I just want to note that one of the reasons why I did choose this topic was because price transparency is very important to the self-funded industry, of course. Not only does it provide us with, plan sponsors with greater opportunities to reduce costs, also to, maybe incentivize participation in certain hospitals that provide quality care, of course, as long as it's allowable with the network. And it's also very important for patients as well, because, a lot of times they, go to the hospital, they have a procedure, and one of the concerns that happens is they're surprised by out-of-network billing for services at an in-network facility, because maybe the anesthesiologist or the radiologist is from an out-of-network facility. And that's one of the concerns that CMS had raised in announcing this rule. So that's why I thought it was, definitely an important topic to address, because of the impact it could have on the self-funded community.
So it is fascinating because I think, and certainly there are a lot of benefits to it, and I know, Brady, you're chomping at the bit. You have some thoughts about this, but just sort of at the 30,000-foot level, things that I've noticed as far as quote-unquote this transparency, and people can't see I'm doing the finger quotes, but you guys can testify I am. There are a couple things that I find fascinating about this, right? First of all is if they're posting their charge master, and it was funny because when this happened, my father, who has, he's retired, he's got nothing better to do than just kind of troll the internet. He saw this, and immediately it's like 2 o'clock in the morning, and he's emailing this to me, and I bet Dad's listening, so hey, Dad, how you doing? And he's like, isn't this what you've been talking about? Isn't this what we need? And I had to explain to him that while it may be a charge master, ultimately how much this plan is paying or that insurance carrier is paying, it's not the same as the number that's being listed. So while it gives you a general sense, it's not the be-all, end-all, like the the menu at your favorite restaurant where it doesn't matter who you are, that's how much you're paying. Assuming you don't replace the French fries with cauliflower or something like that. But anyway, so that was one thing. The other thing, and I understand the value of transparency, but to me, transparency is just one ingredient that you need in the dish. And I don't know why I keep referencing food. I must be hungry, guys. But when you look at transparency, and I always use this example, we brought it up in a webinar, I think, a year ago. I consider, for instance, when you go to the pharmacy and there on the shelf is the store brand, right, acetaminophen, and the Tylenol. And it's the same drug, right? And they're both there, and the price is right there. And Tylenol, the brand, costs more than the generic, right? The store brand. And yet, people who are spending their own money, right? Not even insurance money, but their own money, and the price is right there in front of them, still take the Tylenol off the shelf and purchase that. So that's an example where there's plenty of transparency and there's even skin in the game, right? Because the patient is the one paying out of their own pocket. And yet they're not, in my mind, making the educated decision because they don't realize that there's really no difference between the drugs. They're convinced because it costs more, it must be better. So anytime I hear about this type of transparency effort, I actually worry because if, let's say, hypothetically, you have a patient, they're comparison shopping, right? And they need to go have a procedure done. And they look at these price sheets, assuming they can find it, right? And they look at the sheet and they compare two hospitals. And forgetting high deductibles for now, let's say their out-of-pocket is going to be the same no matter what. If they compare the two sheets and one hospital costs more than the other, will they say, well, good thing insurance is paying for it, I'm going to go with the more expensive facility, right? Think of it this way. If I total my car, right, and my out-of-pocket for a new car is going to be $5,000 no matter what, and insurance says, buy what any car you want, we'll pay the difference. You pay your $5,000 deductible, and any car you purchase is on. And I go online, and, I could replace it with a Toyota Camry for $35,000, or I could replace it for a Bentley, for $500,000. And I say, well, I'm paying the same $5,000 out of my pocket no matter what. I'm going with the more expensive one because presumably it's more expensive because it's better. So isn't there that possibility that unless people are educated and understand that there really is no correlation between price and quality, that this kind of transparency could have the opposite effect than that which we're looking for.
I think that's a great point, Ron, and I'll jump in here because I can't wait to just make my point here.
I am excited.
I think what you're saying, Ron, is we should be training employees to resist psychological manipulation because that's what's going on here. These big manufacturers and drug companies they're paying marketing teams a lot of money to market their product to make the point that if it's more expensive, it's better. And even it trickles down to like the retail store itself when they're placing the products. I used to work for a retail chain, during college, and we had to do some awful task called facing the store where you would just bring the products to the front, as people take them off the shelf. And I believe the brand name product always went to the left of a generic. May have that backward. But the point being that there was always a strategy where you would place the brand name product. Of course, if it was important enough, it'd be on an end cap, as we called it, right? Like right in the front or even near the register, like don't forget to grab this. But the placement of the product matters, the size of the font, all the colors, the generic brands always look kind of like, brownish or like weird colors, like neutral color. Yeah, exactly. You're like, oh boy, it's like cobwebs on it. Like it hasn't been dusted in forever. Like you don't dust the generic. So I think there's a lot of psychological manipulation. Thank you, that's the word. That's gone on. And I think that needs to be accounted for. And what I hear you saying, Ron, is that you're resistant to all forms of psychological manipulation.
Nobody manipulates the peck.
We heard that.
I get that. So I think that's all fair points. But look, Phil, when I read your article, one of the things that struck me was, aside from how well written it was, a lot of critics came out and attacked this rule, and deservedly so. But my point would be, isn't there some silver lining here? This is a first step, right?
It's a first step.
And
I'm glad you mentioned that because, where some of the critics were coming from, well, some of those critics were hospitals who were concerned how the public was going to perceive some of the prices listed. So obviously there's some downfall to some transparency. Obviously hospitals were worried. I don't want to speculate why.
Sure.
But it's important before we go there to highlight what these critics are saying. And it does specifically relate to this new rule. As I had noted earlier on, all it requires is that the hospital post a price list on the internet in a machine-readable format, but there is no guidance on where it should be posted, on the content, on whether that content needs to be clear or consumer-friendly. So as part of my investigation for the article, I did a survey of several hospitals, which I will not name, to see how far they are coming along with this compliance. This rule has been in effect since January 1st. They've had since August to prepare for this. And actually, the proposed rules were released in April of 2018. So there was even more time to prepare for this. Some hospitals had no price list. The hospitals that did have a price list, they were impossible to find absent a Google search. So if I was going to a hospital's homepage, I was not finding any kind of link or reference to pricing. And the hospitals that did have price lists would open them up. I would, just to test it out, I was doing a control find, a word search to find simple, routine services and costs. It was very difficult to find in layman's terms. So even as someone with background in the insurance industry, I was having problems reading those lists. So even though it's a step in the right direction, what those critics were saying was it wasn't enough just yet.
Call me crazy, guys, but I actually don't really care about the prices being listed in particular.
No?
You know what I care about? I care about the fact that the very fact that they're forcing them to post price lists is an indicator that there is an acceptance that all hospitals don't charge the same amount for the same service, regardless of what that price is. Because when you look historically at the way the payer-payee arrangements are structured, there's this attitude in general that, oh yeah, I'm sure an appendectomy at this hospital, maybe it costs a little bit more or less than the hospital down the road, but it can't vary that much. And that's because people in general come from a capitalistic, consumer-based market basis where if you go to one car dealership versus another, maybe you're negotiating it between $2,000, maybe some free service for the first year, maybe a couple points off your financing, right? But ultimately, at the end of the day, you both know, you and the dealership know what the Kelley Blue Book value is, right? What Consumer Reports is posting the fair prices. So you know that you're going to land within a few $100 to $1,000 of each other. And people take that and assume it's the same thing with the hospitals, right? They're thinking, yeah, this hospital charges $8,000 for an appendectomy and this one charges $10,000. They can't even imagine the fact that this one charges 8 and that one charges 80, And the fact that they're now telling them, hey, you have to post your prices is an admission that hospitals don't all charge the same amount. Now, I'm still worried about the fact that the quality metrics are not publicly available and that people may mistakenly take a higher price to equate to better quality. But I agree with you, as a first step, admitting that the prices are different in the first place is huge, at least for me. And when you talk about price transparency and what's the price of care, this leads us to something else that's going on right now, a major hot topic, and that being drug prices and the PBMs. And I do want to raise my hand and bring up what I view as at least a certain level of hypocrisy on the part of our lawmakers, both at the state and federal level, when you look at the dialogue regarding drug prices and the PBMs. And, here I am. I'm literally running to the rescue of the drug manufacturers right now, right? The dialogue consists of PBMs are basically this contractual iron curtain behind which these bad actors commit malfeasance, right? And they're defrauding the consumer. And it's these networks, these PBM networks in the middle of everything with their rebates and their discounts and their tomfoolery, that they're able to allow these crooks, the drug manufacturers, to get away with exorbitant prices. And the response, and you see it right here, right? I mean, there's literally today, right? These articles are coming out about Trump and Azar, their commentary regarding the PBMs and drug prices. We're going to crush the PBMs, eliminate the rebates, remove the contractual hurdles. We're going to force drug manufacturers to reduce the prices that they charge because those costs are exorbitant. And that's how we're going to reduce the cost of the pharmaceuticals and the drugs. And then those same people, when it comes to the cost of healthcare, are saying, we need bigger networks. We need the networks to protect the patients. We need more middlemen, and nobody's confronting about the fact that maybe the prices being charged are exorbitant. So I think it's interesting that the philosophy they're applying to the drug issue, they're not applying the same philosophy to the healthcare issue and hospital prices. And I actually get upset because I know that there are a lot of hospitals out there that are providing amazing service, quality care, for a fraction of the price. So while I think a lot of people are targeting the bad actors, my problem is when you can't recognize who the bad actors are, at the same time, you don't recognize who the good actors are either. And I want to be able to recognize the good actors as much as I want to be able to target the bad.
Well, Ron, can I offer you a cynical political answer to the quandary you just revealed?
Oh, those are two of my favorite words, cynical and political. Those are two of my favorite cows.
Look, it's no accident, at least in my view, that the reason that the drug manufacturers and the PBMs are the target of politicians at the moment is because what's been in the news lately, more so even, I would argue, than surprise medical bills, which usually plans pay, it's pharma bro. It's these manufacturers just raising the price of drugs exorbitantly. And frankly, I think people, for whatever reason it may be, they get more upset by high drug prices, partly because you have a lot of seniors who are struggling to pay for their pills or their medications. I think you have people who are paying more out of pocket for drugs than they are for hospital services, right? So this gets more attention in the news, and therefore, for better or worse, it gets more attention in Congress. Actually, unlike the tweets at the manufacturers, you've got actually proposed rules targeting PBMs and rules that actually matter and don't have the kind of problems that Bill's outlined with this particular rule. So I think once, and it's building, you can see it already. There are more stories out there now about surprise billing in many more contexts, but I think the noise level sort of hit the ceiling with drug pricing, and it was, I think, the first thing which both parties could agree on tackling first. That's why I think you're seeing that happen now.
Yeah. And, ultimately, I think maybe it's if it works out and we as a nation in general learn how to better control cost and we experiment with the drug issue first, maybe we take those lessons learned and then move on to the next cost driver, whether it's hospitals or something else.
And for one lesson learned, Phil, I want to ask you in our closing minutes here, what do you think could be done to this rule to make it better? What have people suggested to fix this problem?
Well, I think some additional guidance would be helpful in making some kind of uniform approach on how hospitals should be posting these lists. Possibly guidance which requires hospitals to make their list publicly available, but on their homepage, as opposed to buried within their website or to the point where a Google search has to be used to find these lists. I think some more guidance as well, and even some more regulations on the content of these price lists. Because even though CMS does encourage hospitals to make these price lists consumer friendly, they don't define what consumer friendly means. So with that said, hospitals are obviously just putting information out there, but maybe not in a way that's easily understandable. And some of these lists as well are not including facility fees and things of that nature, which if you really are price comparison shopping, once you get to that hospital, the bill's going to be totally different, most likely than what you anticipated. So I think more transparency there as well would be needed, because there's all these hidden charges, and I didn't find anything on any of the price lists I reviewed that even noted the price of a bed.
Right.
So
it reminds me of when I purchased my first home, It's you go onto Zillow or Redfin or one of these real estate websites. It's like, oh, this home is fabulous and only 500,000, 250,000, 300,000. You're looking, you're like, I can afford that. And then by the time it's over, man, that is not what you paid. You end up between inspections and attorneys and closing fees. Yeah, it is amazing. But maybe everybody can relate to some of these, and we could start to show them that some of these common economical factors that come into other parts of their life apply to the business of healthcare as well.
Who knew?
So,
Yeah.
So guys, great discussion. Looking forward to seeing how things shake out. Whether you love it or hate it, I think at least we're headed in a direction.
Definitely.
And change is good, at least here. So on behalf of myself, Brady, Philip, Pat the Man Santos, our producer, I hope future world champion New England Patriots. Go Patriots. After this weekend, we'll go back and listen to this podcast, and either we're going to sound like fools or sound like Nostradamus. But either way, and on behalf of the FIA Group and all of its partners, allies, and friends in the industry, we thank you for listening to the Empowering Plans podcast, and we'll catch you again soon. Thanks so much.
Thank you.